Hello everyone, this is Dr. Pruett. Today we are going to be talking about our patients with liver failure and things we need to think about as we approach these patients and have a deeper understanding of what actually is going on in their body. So like always, let's start with an anatomy review. The liver is located in the right upper quadrant of the abdomen, just underneath the diaphragm, and is really close to the stomach, the first part of the intestines, and it's got this very important junction here of the gallbladder and the pancreas. And both the gallbladder and the pancreas are located there to help with digestion as food comes out of the stomach. So very important little quadrant here, right above the belly button, a whole lot going on. The liver also has a very large amount of blood flow. If you look, it sits right on top of the aorta. The inferior vena cava runs right behind it, and there's actually a hepatic vein that's integral to the liver to drain blood and get that back to the heart. But not only that, a special thing about the liver is this portal vein here, and this comes off of the intestines and brings nutrients and things to the liver to be filtered. And this is integrally tied to the bile ducts that lead into the gallbladder and help with digestion. So the liver has a whole lot going on, very important metabolic organ, lots of blood flow. And here's a closer look at the hepatic portal circulation that I mentioned earlier. You have your hepatic portal vein here, and if you look at what's going on, you have your patient is eating here, right? So food comes down the esophagus into the stomach and is going to go out into the intestines to be absorbed. And a large part of that absorption process happens through the venous system that's integrally tied to the intestines. And as it comes back, all of those nutrients that are absorbed are going to be going directly to the liver to be processed and either saved and recycled or sent out as waste. And so a lot of blood flow, a lot of nutrient flow. Very important venous system here. Bile production is another very important function of the liver. Bile comes from actually the breakdown of red blood cells. So red blood cells last an average of about 120 days in the body. They go to the spleen where they're recycled, and as they're broken down, they become unconjugated bilirubin. Then they're taken to the liver, but by itself, bilirubin needs to bind to something, so it tends to bind to albumin, which is a carrier molecule, just to keep things safe in the bloodstream and not throw off the pH balance or the electrolyte balance. And it's taken to the liver, where it's conjugated or matched with another molecule and then can be processed through the gut. And it's either processed in the stool or the urine or back through the enterohepatic circulation through the gut and recycled. And so actually, the breakdown of red blood cells and the high iron content that leads to that as they're metabolized in the body is what makes our stool brown. It's the iron content and the bilirubin in stool that turns it brown. So interestingly, when you have a patient with a biliary duct obstruction who's not processing bile correctly, you can ask them if their stools have changed color, and frequently their stools will be more white in color than brown because they're not processing bile like normal. Okay, we already talked a little bit about bilirubin metabolism, but here's just another look at it. Red blood cells are broken down by the spleen. They're carried by albumin to the liver. The liver processes them, either stores some bile in the gallbladder or sends it out through the gut to be sent out through stool or through urine in the kidneys. One of the liver's major jobs is to be a filter. Just like we talked about all that blood that's coming back from the enterohepatic circulation, that's a fancy name for all that blood that's absorbed from the GI tract. The nutrients will either be recycled and broken down into their parts and pieces and rebuilt for what the body needs, or will be sent out in the stool or the urine as basically waste. The liver also, as part of its metabolic processes, it makes very important things in the body. And this is important to know because these are things to think about in your patients that have liver failure, because they're not going to be able to make them as effectively. So glycogen is one of the body's stores of extra sugar. So if you were ever to get hypoglycemic and not eat for a while, say a long fasting period, the body, specifically the liver, stores glycogen so it can be broken down in a fasting state and still supply glucose to the brain. So if you have a patient who's got liver failure, they're very prone to hypoglycemia because their liver isn't able to make and store glycogen like normal. Another important thing that the liver does is make proteins. Proteins are important for a multitude of things in the body. These are the body's messengers, and so they're incredibly important in the immune system. They're very important for clotting, and not only that, but one of the major proteins in the body that we rely on more than we realize is called albumin. And this is that carrier molecule that we talked about that basically binds to bilirubin. It binds to a lot of other stuff too to keep things safe in the bloodstream and manage that electrolyte balance in the body. So without this, there can be pretty profound consequences in terms of fluid management inside the bloodstream. The liver also makes cholesterol and fatty acids, and it also converts toxic products from the body into urea to process them correctly. And we'll talk about that a little bit more in a minute. There's lots of causes of liver failure. It can be anything toxic from the environment, whether that's intentional ingestion or not. Alcohol, of course, is a leading cause in our country. There's inflammation that can be due to infection. Hepatitis is a common one. Sometimes heart failure, as there's venous congestion on the right side of the heart, can lead to back up into the liver and lead to liver failure that way. And there's inherited diseases that do it as well. And so over time, no matter what is the precipitating cause, there's chronic inflammation, and that leads to scarring in the liver. The liver becomes really hard and scarred. There's not as much easy return of blood flow. The metabolism starts to slow down, and then we get the consequences that we see of liver failure. So the most common causes in our country are going to be hepatitis. We have very high rates of hepatitis C in our community, and that is closely linked to alcohol abuse. And not only that, but actually Tylenol overdose, so over-the-counter medication, is one of the leading causes of liver transplant in the country. So those are our top 3 causes of liver failure. There's some other causes as well. Genetic or autoimmune diseases can do it, as can certain poisoning. So mushrooms is a not uncommon side effect either. So the pathophysiology of cirrhosis, if you start with a normal liver, well, we saw a lot of blood flow, things moving in and out, a lot of metabolism going on, a lot of nutrients going in and out, a lot of recycling and building going on. As inflammation occurs or as cell death occurs, every time cells die, there's going to be other healing cells that come in, and that causes inflammation. And so as the liver becomes inflamed, first what you're going to see is kind of a fatty infiltration, and things get kind of congested and the liver gets really big. And over time, as that inflammation becomes more chronic, it causes the liver to scar down. And we all know that scars make things stiff and non-compliant and kind of less porous. And that's a really bad thing in the liver, because the liver is dependent on the free flow of blood and nutrients to do its job. And so as the liver becomes scarred down and hard, it actually shrinks and is less able to have the blood flow that it's used to. So what you tend to see is patients who are jaundiced. It's called icterus if you see it in the eyes, because they're not able to conjugate their bilirubin like they normally would. They tend to get a lot of fluid buildup, and this is because they're not producing albumin like they normally would. There's venous congestion, which is called caput medusa, and you can actually, if you lift up the shirt, sometimes you'll see this large abdomen that's full of fluid here, and you can actually see it on this abdomen too. You'll start to see veins sticking out. This is a really profound case here where you can see the veins on the stomach, but you can see it here too, where they start to stick out, and that's just due to the pressure and the backup from the liver that's so scarred down and hard. It's not, the blood flow tends to back up. As the liver is not able to process the fatty acids, you tend to get increased estrogen and breast development in males. The nails will change. Sometimes you'll see redness in the palms, and you'll start to see little skin changes called spider nevi. And as the liver failure is leading to decreased protein production, another thing that the liver is not able to make is platelets. So liver failure patients tend to have very low platelets, which leaves them very prone to bleeding and bruising. So you might see a lot of bruising on your liver failure patients. So some of the complications and when you're approaching these patients that you need to think about is think about that hard, scarred down liver that's very difficult to get blood flow through. And I think about it as a clogged filter, which is essentially what it is. You just can't get anything through as easily as you could before. And that's just due to the scarring and the chronic inflammation. And so as there is scarring in here and there's all that blood flow trying to get through every minute, the blood flow tends to back up. And if you remember, your venous side doesn't have very high pressures. It's a very low pressure system. And so frequently it doesn't have enough oomph to push that blood through the liver where it needs to go to get back to the heart and get back into circulation. And so there's something called portal hypertension, which just means that the pressure in the portal vein is higher than normal and it tends to back up. And if you look where it tends to back up, it backs up into the esophagus and it backs up into the stomach and into the gut. So what happens is that blood backs up into the esophagus is you get esophageal varices, and that's just a fancy way to say that the veins in the esophagus are dilated from the backup because blood can't get through the liver as easily as normal. Now the problem with this is that it can cause life-threatening bleeding. So these are veins, they're very thin-walled, they're very friable, and they can cause very profound bleeding because they're under higher pressure than normal. And not only that, but let's say your liver failure was caused by alcohol. Well, with that, that's a little bit caustic to the gastric mucosa, and it also can cause a lot of vomiting. So if you add vomiting, you add gastric acid, and you add a caustic substance to these very thin-walled veins, it makes these patients very prone to bleeding, and I've actually seen patients bleed to death from this. These are very dangerous. And speaking of bleeding, not only are gastric varices prone to bleed, but then you add the fact that these patients are prone to bleeding because they're not making platelets like normal, which normally help with clotting, and they're also not making other clotting factors, specifically and most importantly vitamin K. So functionally, it's like these patients are on Coumadin. They're automatically anticoagulated because they don't have the normal vitamin K clotting factors that other patients do because their liver's not functioning like normal. So as a consequence of their coagulopathy, you might look at their ankles or their wrists and see these little things called petechiae, these little tiny red bumps. Sometimes they're raised, sometimes they're not, but that's capillary rupture where the little tiny capillaries at the end of the blood vessels are actually bleeding, and that's because they don't have enough clotting factors. We've mentioned bilirubin before. There's just a malfunction in the way that the red blood cell breakdown is happening. The liver is not able to conjugate the bile anymore, and it tends to build up, and that's what causes them to look so jaundiced. And this can be worse because not only is the normal cycle of red blood cells being broken down, where they get broken down naturally every 120 days, but these patients are also having microscopic bleeding, so they're breaking more red blood cells down than normal, and that's going to increase their bilirubin load. So there's a couple different things that cause jaundice in our liver failure patients. One I just mentioned was the overproduction, and so as these patients are bleeding or their red blood cells are breaking, they're going to have an increased bilirubin load. But two is inadequate processing. So we talked about the need for albumin, or the need to conjugate the bile in the liver. The liver's not going to be able to do that as effectively as it normally would because it's scarred down and dysfunctional. And then in addition to that, there's going to be decreased excretion. Could be another cause of jaundice. And so this doesn't always have to go with liver failure. This can simply be due to a bile duct obstruction. So whether that's gallstone in the wrong place, or sometimes pancreatic cancer can do this as well. So it's not just liver failure that causes jaundice, but frequently it is. Another important thing, and we see this actually a lot in the field, is hepatic encephalopathy. And this is due to the inability to process ammonia. And so it has to do with the urea cycle, but as protein is broken down, and if you think about things in the body that provide protein, so number one would be diet, if you have a diet high in protein. Number two would be if you're breaking down red blood cells, which have some protein in them. And number two would be infection, because a lot of the cell signaling messengers in the body are proteins. And so if you have an increased protein load, that's going to increase your production of ammonia. And usually ammonia binds to albumin and is taken back to the liver and can be processed and sent out either through the urine or the stool and is safe. But the problem is, if you have increased protein breakdown and this NH3, this ammonia, can be toxic and you don't have enough albumin in your blood to transport it because your liver isn't making it, then this NH3, there's too much in the bloodstream and it goes to the brain and causes confusion and altered mental status. So here's what happens. You get this protein breakdown from either infection or blood loss or whatever, tries to go to the liver, is not carried by albumin, gets shunted away, ends up going straight to the brain and is directly toxic to neurocells. And so patients who are encephalopathic, who I know have a history of liver failure, I tend to ask them 3 different questions. Number 1, I want to know if they've had any GI bleeding, because I know that they're prone to bleeding, whether from their esophageal varices or from their stomach or their portal hypertension. If they're breaking down more red blood cells than normal, that could lead them to be more altered than normal. I ask them about infection because as they're not making the normal proteins that they do, they're functionally immunosuppressed. And then I ask them about their diet, and I'm trying to figure out why they're having such increased protein breakdown. One of the ways to evaluate for hepatic encephalopathy is to look for something called Asterixis. And this is actually a hand flapping tremor, where if you tell the patient, hold your hands out like you're stopping a car, and you see the man on the left doing it, if you push on their hands, or sometimes you don't even need to push, just as they're holding their hands there, you're going to see them start to flap like the guy that you see here. And that's pretty diagnostic for hepatic encephalopathy due to that ammonia buildup in the brain. Not only is ammonia toxic to the brain, but so is bilirubin. So in your jaundice patients who are altered, we know that this is a problem in infants actually who are born jaundiced. It can cause long-term brain damage, but in our liver failure patients as well, it can be another cause of their altered mental status. The unbound bilirubin is directly toxic to the astrocytes and the neurons in the brain and can lead to long-term encephalopathy if not treated. So if you have a patient who's altered and has a history of liver failure, there's some things we need to think about. One is hypoglycemia. We talked about their inability to make and store glycogen, so make sure you're checking his sugar. They are very prone to dropping their sugars pretty quickly. Think about encephalopathy. So we talked about ammonia buildup. Ask them if they've had a GI bleed lately. Are they taking their medications? The medication that patients usually with end-stage liver failure are given to help them not be encephalopathic, it's called lactulose, and that just helps bind the ammonia. Patients don't like to take it because it makes them go to the bathroom more often than they like to, so sometimes they'll just be encephalopathic because they're not compliant with their medications. And then make sure you're asking about infection or sepsis, specifically if they have any pain anywhere or they've had fevers, because they are immunosuppressed. I know we see a lot of liver failure and we know that they tend to get edematous, and the reason that that happens again goes back to albumin. I think of albumin as a very negatively charged ion that floats around in the bloodstream. I kind of think of it as a magnet, and it holds fluid in the vascular space. So water has a very weak positive charge, and if you put a very negative charge in the vascular space, which is albumin, it's going to pull water in and keep it in the vessels and outside of the tissues. But if you don't have enough albumin in your bloodstream, the water is going to leak out, and that's exactly what we see in our liver failure patients. So the water is going to leak everywhere. It leaks into their belly, it leaks into their ankles. Sometimes they get so edematous in males it can go all the way into the scrotum, and you can get some pretty profound scrotal edema. And not only that, but into the lungs, so you can get pleural effusions and some respiratory distress from it as well. So be very, very careful in your patients with liver failure with any fluid resuscitation, because realize whatever fluid you think you're giving in the intravenous space, if they're at the end stage of liver failure and their albumin is low, they're not going to be able to keep that fluid in the vascular space, and you're basically just going to be making their edema worse. And this is one of the ways that low albumin is manifested is called ascites, and that's just abdominal edema is what it looks like. It looks like usually these patients, their muscles are wasted, and it looks like they swallowed a basketball, or like they're 9 months pregnant. And that's due to the low albumin, the increased pressure in that portal circulation that can't get the blood through the liver from the gut. And then that backs up into the kidneys eventually and causes the kidneys to have a really hard time regulating salt. And that also affects the fluid balance. The way that we treat this in the hospital, if it's getting to the point where the patient is hypoxic or having a hard time breathing, or it's just functionally untenable size of an abdomen, they get something called a paracentesis, and that's literally just finding a fluid pocket with an ultrasound in the abdomen and sticking a needle in and pulling the fluid out. Sometimes we can get up to 10 liters out of the patient's abdomen. Realize that as the ascites gets worse and as these patients are nearing the time when they need a paracentesis, it can cause some pretty profound respiratory distress. There's the mechanical pushing of the abdomen against the lungs, so there's decreased tidal volumes, but not only that, sometimes the lungs can get fluid in them as well. So if you need to, you can add some positive pressure with CPAP just to help with that respiratory effort and counteract the pressure that's going on in the abdomen from the fluid retention. With the ascites and the fluid and everything in the abdomen, sometimes the bowels themselves become leaky and the cellular adhesions start to open up, and bacteria from the gut can translocate into the abdomen. So if you have a patient with liver failure and ascites who is telling you that they have abdominal pain and have had fevers, have a high degree of suspicion for something called spontaneous bacterial peritonitis, we refer to it as SBP. But basically it's due to the fluid shifts in the body. The bacteria from the gut infiltrate the abdomen, and that patient needs antibiotics. So common presentations for our liver failure patients, I know you all know this because we see it frequently, but a lot of times they'll be short of breath. That can be due to that big, large, distended abdomen full of ascites. If you need to and it's profound shortness of breath, don't be afraid to use CPAP to just give them a little bit of positive pressure to counteract that abdominal distension. If you see abdominal pain in a patient with ascites, ask about fever, think about SBP, think about sepsis. If they're altered, ask about GI bleeding, ask about their diet and their medication adherence, because it could be hepatic encephalopathy. And then always be aware that these patients tend to bleed. So if they've been vomiting, if they have esophageal varices, if they fall and hit their head, realize that their platelets don't work like normal and they're functionally anticoagulated. Really, there's not a whole lot you can do other than take a good history and do supportive care on the way to the hospital, but these are just things to think about as you're approaching these patients. And that's all I have. If you have any questions, let me know.